There is an increasing number of pelvic surgical interventions in urology leading to possible postoperative urinary incontinence. Another open surgery only treating iatrogenic stress urinary incontinence may not be acceptable. Transurethral bulking agents are a minimally invasive form of treatment, which is an excellent method for low-grade incontinence. Although submucosal bulking agents have been known for years, recently developed agents with the ease of application, inert tissue reaction, biocompatibility, lack of migration, and moderate price have the potential to make this technique a successful, popular technique for treating postoperative stress urinary incontinence. The aim of this video is to demonstrate relevant anatomy, application technique, and clinical cases.
Recent studies have shown that the prevalence of male urinary incontinence is higher than previously assumed. Peter Boyle and co-authors, for example, found mild to severe incontinence in 11% of more than 4,800 men studied at 4 centres in Europe and Asia. It is of note that almost 6% of European men in this study were using incontinence pads. An increase in pelvic oncological surgery for urological malignancies also raises the incidence of incontinence. In centres with low-volume surgeries performed for prostate or bladder cancer resection, incontinence may be as high as 40 to 65%. But even in centres of excellence, incontinence after cystectomy and orthotopic bladder substitution reaches up to 20%. The rhabdosphincter is not an exactly ring-like structure as nicely depicted on this illustration. The exact dissection in the area of the prostatic apex allows the preservation of a segment of membranous urethra that, after anastomosis to the bladder neck, provides an area cranially to the rhabdosphincter which is ideal for the placement of bulking agents. In this anatomical specimen, which has been opened in the median plane, you can see the urethra with the catheter, the membranous urethra, and the rhabdosphincter located in this plane just ventrally and laterally to the apex of the prostate, as well as the membranous urethra. Modern version bulking agents are mostly biocompatible, but neither resorbable nor biodegradable. Their placement is accomplished by transurethral injection via a standard 14 Charrière cystoscope with a small caliber working channel. A 23-gauge needle is used. We prefer needles that have a marking at the end showing us how deep the needle tip is located submucosally. The needle tip must allow a good penetration of the mucosa. Its diameter should be as small as possible, but still large enough to allow injection of the viscous bulking agent. As bulking agent, we prefer a substance consisting of non-biodegradable dextrane particles suspended in hyaluronic acid. Apart from other features, the low viscosity allows a small gauge needle. Even though the bulking agents are administered in a non-surgical fashion, the implants are permanent. The procedure requires therefore almost aseptic conditions like for any open surgery. The distal third of the urethra usually harbors bacteria, and therefore prepping of the external genitalia requires generous application of aseptic gel into the urethra as well. The size of the endoscope should be adequate for the size of the urethra. Lacerations are not only a problem for vision, but also a possible source of infection post-operatively. The procedure should be done under the same sterile conditions as any other aseptic operation, which means, for example, the wearing of suitable gowns, hoods, and masks by everybody in the room. Apart from a careful prepping of the patient, the washing procedure should be the same as, for example, for artificial implants. To avoid an unsterile eyepiece, a camera should be used for the endoscope. During endoscopy, making an endoscopic incision can be a reason to postpone the procedure. After a careful inspection of the urethra and the bladder, the needle is inserted into the working channel and made visible endoscopically into the bladder. The scope with the injection needle in position is then retracted to the area just above the external sphincter. At an angle of 15 to 30 degrees, the needle penetrates the mucosa for approximately 5 millimeters, in this case until the white coating is visible. After the desired amount of agent is injected, the position of the needle should not be altered for 15 to 20 seconds to allow the substance to settle in the tissue. Whenever possible, the bulking agent should be located just above the rhabdosphincter as outlined in this anatomical specimen. Knowing that we introduce the needle approximately 5 millimeters, the location of the insertion into the submucosa can be in the area of the rhabdosphincter. The injection itself will then still be just above the sphincter. The bulging of the mucosa during the injection can be monitored endoscopically. Excessive injection leading to immediate or delayed rupture of the overlying mucosa can thus be avoided. Larger defects usually require 4 sites of injection, at times even a second or third vial of substance. A defect caused by scarring after a surgical laceration may only require 1 or 2 injections. As you can see, reducing the irrigation helps to determine where additional injections may be necessary for an optimal closure of this area. This graphic illustrates the possibility of using a bulking agent to reduce post-operative scarring. In general, a submucosal cushion improves mucosal coaptation during the sphincter action. In addition, a filling defect can be treated. Laplace equation explains some of the affection of a bulking agent in the area of the sphincter. By reducing the intraluminal diameter with the help of submucosal bulging, the sphincter pressure or tension needed to reach a certain interluminal pressure is lower. Post-operatively, the patients should avoid sitting on hard surfaces. Inflatable rings like the ones used after perineal prostatectomy may be useful. The patients should not use standard bicycle seats for 6 to 12 weeks. No pelvic floor electrostimulation using anal electrodes should be done for at least 2 to 3 weeks. A reinstallation is possible. As a matter of fact, according to our results, the majority of patients do need a second or even third procedure. The interval should be at least 8 weeks, better even 12 weeks or 3 months. Usually some portions of the bulking agents remain from the first procedure, and therefore fewer injections are necessary. Final aspect, there is still good sphincter motility despite optimal closure. With regard to the alternative, being major surgery, transurethral injecting of bulking agents is a minimal invasive procedure with a success rate which clearly justifies its attempt.